I'm Mark Campbell. I'm a medical oncologist in Grand Rapids, Michigan, and I'm going to help you understand why we don't cure everybody with cancer. Hello, I'm Mark Campbell. I'm a medical oncologist in Grand Rapids, Michigan, and I'm trying to illustrate for patients in a obviously simplistic way some of the concepts of the treatment and why we're doing some of the things that appear sometimes crazy to do. I'm always asked, why don't we cure anybody? What's the problem? And it's very complicated, and I'm not going to go through all of it today. But I want to first say that one of the problems is these seeds come off. We talked about them in a segment a little bit longer earlier ago. That the dandelion can blow a seed away. That seed can lie dormant for years sometimes. It's hard to understand why that is. But that seed can lie dormant and then for reasons we don't understand begin to activate again. And we're learning some of those activation triggers, but we don't have them all. But if seeds never came off, whenever we get around to the tumor and remove it, then we'd be fine. But you never know when the seeds come off. Sometimes they come off from very early. Sometimes the tumor gets very large and they never come off. But the seeds coming off is one of the bigger problems that we have. But the one I wanted to kind of focus on right now is a second one. Let's say that this is 100 cancer cells, and we magnify it 1,000-fold under the microscope, so now we can see it. And we see all 100 of those cells. And like dandelions, maybe we come home from work every Friday after work, and we spray the lawn with dandelion killer, and all the dandelions are dying real well, and everything is going fine. But if out of that 100, we kill 99 of them, but there's an oddball one in there, the red one, crabgrass. And you can keep spraying dandelion killer all you want on it, and it's not going to kill the crabgrass. Why can't dandelion killer kill crabgrass? I don't know, but it doesn't. And what can happen later is the crabgrasses can start growing. So does that mean we're dead in the water? No, it means we've got to switch medicine. So in this fancy word of drug resistance, very, very, very common in antibiotics, that for whatever reason, the first antibiotic or the first chemotherapy does not match the red one. So we can be improving and everything is going better and the tumors are shrinking and the blood tests perhaps are improving. But at some point, we see that we didn't get it all, or in fact, there's actually some enlargement again. And that usually implies a drug-resistant clone. Well, what would be a strategy for that? For example, a little old lady comes in the emergency room Friday night, very ill, near death, bilateral pneumonias. And what antibiotic do we give? We won't get cultures for 48 hours. So we have to, not guess, it's an educated guess, but we have to pick an antibiotic. So we'll often maybe give 2 or 3 antibiotics. So we might give drug A, B, or even A, B, and C, at least for 48 hours until we can get reports back and we know it more specifically. But the more importantly is she's still with us on Monday. So sometimes one of our strategies have to be that we give multiple chemotherapy agents to try to get around this potential. And here's another element of this difficulty of drug resistance. The bigger the tumor is starting, the more likely there can be oddball ones in there. And the more likely there can be drug resistance. So we need, as much as possible, to try to start the treatment when the tumor is smaller rather than far advanced, because then the likelihood of drug resistance is so much greater, and our ability sometimes to cure it then is not possible. So the strategy is to start often with combinations of treatment and try to do it as early as possible in the illness.